Today, we're not just, scanning the headlines. We're really opening up the foundational playbook of modern immunology. We've got this really deep stack of sources that guides us through the strategic arsenal the body uses and how we help it defend itself.
That's right. And for you, the learner, this is really about getting technically proficient and fast.
Yeah.
We want to move past the common, often simplified narrative around immune defense.
Right.
And really dive into the precise biological products used to reinforce our systems against foreign agents.
Yeah.
Microbes, viruses, even their toxins.
So our mission today is to understand the absolute operational differences between the body's main immunological tools. We're talking vaccines, Antisera, and immunoglobulins.
Yeah.
And the crucial takeaway here for you is recognizing why a doctor would choose one over the other. Because that choice, it dictates the difference between long-term security and immediate, sometimes life-saving, but temporary protection.
And to start, we really had to establish the core concepts. These biological products, they fall into two enormous categories. And it's all based on how they make the recipient's body respond.
We're dealing with the big two approaches to defense here.
Exactly. So first, you've got vaccines. These are antigens. And their whole purpose is to get your body to do the work. They induce what we call active immunity.
Oh, captive immunity.
Then second, you have Antisera and immunoglobulins, or IGs. These are completely different. They're ready-made antibodies. They provide an immediate transfer of defense. That's passive immunity.
So active versus passive.
Understanding that split, that is the key to unlocking the entire field of immunological strategy.
Okay, let's unpack that. Let's unpack this fundamental divide, because this feels like the operational truth that guides every single choice a clinician has to make. Active immunity. This is where the magic of long-term defense happens, right? But it comes with a cost.
Yeah, and that cost is time. We call active immunity the training drill. It's imparted by vaccines. And the mechanism is, it's a fundamental biological challenge. You introduce an antigen, a harmless version of the threat, and your body sees it as foreign.
And that forces it to act.
It forces the recipient to produce their own specific antibodies. And, sometimes develop cell-mediated immunity too, like training specific T cells.
So we're not just building the military base here. We're selecting the recruits, teaching them what the enemy looks like, training them, and then deploying them. It's a whole process.
That's a perfect frame for it. And the characteristics of this self-generated defense, they're just superior. It's significantly more effective and far, far longer lasting. I mean, potentially decades of protection.
But
because you're relying on the body to go through this whole training cycle from seeing the antigen to peak antibody production. It requires a pretty substantial latent period.
a waiting period.
Exactly. Our sources say this can be anywhere from 1 month to, several weeks before that protective response is fully up and running.
So it's future-proofing the body, but it's kind of useless if the enemy is already at the gates. And the sources are pretty specific that it's about preventing future disease.
Now, let's flip that equation. Let's talk about passive immunity, or what we call the immediate transfer.
Okay.
The need for this comes up when the body either can't wait for that latent period to pass, or, and this is key, when the immune system is too compromised to even mount a decent defense on its own.
Right, so if the snake has already bitten you, you don't have time to train the troops.
You need instant defense.
Exactly.
And the mechanism here relies on Antisera or immunoglobulins. These are antibodies that have already been produced by a donor, either another person or an animal that was immunized before. Then these ready-made defense units are just transferred to you.
So instead of going through the training process, you are literally airdropping fully trained, experienced soldiers, the antibodies, right into the battle zone.
That analogy holds up perfectly, and for two really critical reasons. First, because the antibodies are there immediately, passive immunity gives you immediate protection. There's no waiting.
But the second reason...
The second reason is that because your body didn't make them, the defense is entirely temporary. Your body sees them as foreign material eventually and just clears them out.
The sources did mention the half-life, though. It's not like they disappear in an instant.
No, that's a crucial detail. For IgG antibodies, which are the main type transferred here, the half-life is actually pretty long, over 20 days. So while it's temporary compared to active immunity, that's still several weeks of a strong, immediate shield.
And this leads to the critical difference in how they're used. Active immunity is for prevention, but passive immunity, it's a dual role player.
It can be both curative neutralizing, a threat that's already there, like a toxin, and prophylactic, so preventing an infection after you know you've been exposed.
Which brings us to that trade-off insight. The core decision is always time versus duration. Do we need a slow, durable defense or immediate short-term coverage?
And sometimes you need both. You use them at the same time. You provide the immediate shield with passive immunity while the long-term army from active immunity is still being built.
Like with tetanus or rabies exposure, which I know we're going to get into.
We will. But before we jump into the different vaccine types, the sources are incredibly strict about the general logistics. They emphasize that all these products are biological agents. They need strict safety measures.
Right, this isn't like picking up aspirin.
Not at all. The manufacture, the quality control, distribution, it's all strictly supervised by state health authorities. And the reason is, these are complex bioactive compounds. They have to be standardized by bioassay.
A biological test, not just a chemical one.
Exactly, to make sure they actually work. And critically, they all require cold storage. The cold chain is everything. If a vaccine gets warm, its efficacy can just plummet. You're left with a false sense of security.
Okay, let's move beyond the active-passive frame now and really drill down into the 3 specific ways we generate that active immunity. Killed, live attenuated, and toxoids.
So the sources define vaccines as antigenic materials from a whole microorganism or one of its products. Let's start with type I, killed inactivated vaccines.
The name tells the story here. The method is simple. You kill the microorganism, usually with heat or chemicals. Why do that?
Well, killing them removes any possibility of them replicating or causing disease. You're presenting them to the immune system in a safe, intact form. It's basically a mugshot.
A mugshot, I like that. But the downside is that because they can't replicate, the immune system doesn't get a very strong or continuous signal, right? Not like a real infection.
That's the key limitation. The antigenic load is fixed. So the immune response they generate is generally a bit weaker and shorter lasting. And that dictates the whole regimen.
Meaning you need more shots.
A lot more. Killed vaccines generally require a whole series of injections for the primary immunization, followed by booster doses every few months or years just to keep that protection up. It's a high-maintenance category.
And yet it's central to public health. The list of examples is huge. Bacterial threats like typhoid, pertussis, meningococcal, Hib. And on the viral side, major ones. Polio, the Salk version, rabies, influenza, Hep A, Hep B.
Now, compare that to type 2, live attenuated vaccines. This approach takes a much more calculated risk.
For the sake of better immunity.
For better, longer immunity. Here, the method involves using live bacteria or viruses that have been made virulent.
Weakened, tamed.
Exactly. They're designed to multiply, but only to a limited extent inside your body. And that limited replication is the core strength of this type of vaccine.
Because it mimics a natural infection, even a mild one, it gives the immune system a much richer, longer-lasting training exercise.
Spot on. The result is significant. They usually produce powerful, long-lasting immunity, often with fewer doses and fewer boosters.
And the examples here are the foundations of childhood immunization.
Absolutely. On the bacterial side, you have BCG for TB and the oral typhoid vaccine. For viruses, it's the big ones. Polio, the Sabin version, measles, mumps, rubella, and varicella.
But that benefit, that long-lasting immunity, it brings us to a really critical, high-stakes safety warning. Because they are still live, the sources are emphatic about who can't get them.
This is the critical trade-off of the live vaccine approach. Because the organisms are alive and replicating, live vaccines are absolutely contraindicated in anyone with an impaired host defense.
So let's define that. What kind of conditions put someone in that high-risk category?
The risk is there whenever the immune system is suppressed or compromised. So we're talking about individuals with leukemia or other malignancies, especially if they're on cytotoxic chemotherapy.
Drugs that kill immune cells.
Right. It also includes people with severe autoimmune conditions like lupus, anyone on high-dose corticosteroids, and of course individuals with AIDS or other severe immune deficiency states. For these patients, that mild infection from the vaccine can become a full-blown life-threatening one.
That's incredibly serious. The sources also had a specific rule about timing if you need 2 live vaccines.
Yes, if you don't give them on the same day, they have to be separated by a minimum of 1 month.
Why is that?
The thinking is that it allows the immune system to fully respond to the first challenge and stabilize before you hit it with a second live replicating agent. You want to avoid any potential immunological interference.
Okay, that's a massive takeaway. Let's move on to the third type, toxoids. This is a niche but really powerful category.
Toxoids are very specialized. They are used against the potent exotoxins produced by certain bacteria. The big two are diphtheria and tetanus.
So how do you make a toxin safe but still useful as a vaccine?
It's a very precise chemical process. You take the exotoxin, the actual poison, and you modify it, often with formaldehyde. The goal is to remove all the toxicity, but, and this is crucial, you have to retain the specific 3D shape that makes it antigenic.
So the body learns to recognize the shape of the weapon, but the weapon has no bullets.
That's a great way to put it. The body learns to fight the poison without ever experiencing the poison itself. And the sources note that toxoids are highly successful, often giving even more prolonged protection than many standard bacterial vaccines.
And finally, let's talk about efficiency, because giving a kid all these shots is a logistical nightmare. So we have combined vaccines.
This is all about logistics and adherence. Why stick a child 3 times if you can package 3 or even 5 antigens into a single shot?
We started with things like the double antigen for diphtheria and tetanus, then the triple DPT.
And now we have the pentavalent vaccine, which is a marvel. It combines 5 defenses: DPT, hepatitis B, and Haemophilus influenza type B, and of course the viral superstar, MMR, measles, mumps, rubella. These combinations just streamline the whole process.
Now that we have the classifications down, let's get specific. The real insights are in the details, right? The efficacy rates, the complex schedules. Let's start with bacterial vaccines, and let's use typhoid as a case study. It really shows how the strategy has evolved.
Typhoid is a fantastic example. The older TB vaccine, a killed formulation, gave you about 70% effectiveness, but only for 1 year. You needed a booster every single year.
That's a huge logistical burden for a population. So how does the Vabisaccharide vaccine improve on that?
Well, the Vita polysaccharide is just a single 0.5 milliliter dose. It gives you a similar efficacy, around 72% protection, but it extends that protection to 3 years.
That's a huge gain.
It is, but it has a key limitation. It's not approved for kids under 2, so you're missing a really vulnerable group.
Which brings us to the third option, the oral one, which changes the whole route of defense.
The typhoid Ty21A oral vaccine. It's a live attenuated strain of S. typhi. By giving it orally, you're trying to mimic the natural route of infection through the gut, which is where typhoid starts.
And that gives you a better gut-level immune response.
Exactly. Mucosal immunity. It's often the body's first line of defense.
Okay, moving on. Let's talk about meningococcal and Heb.
The meningococcal vaccine uses purified bits of the bacterium's capsule, and the protection it offers is fast. You get about 90% protection within just 2 weeks of the shot.
And the Heb vaccine for Haemophilus influenza type B, it's a conjugated vaccine. What does that actually mean?
Conjugation is a clever molecular trick. You take the polysaccharide, the sugar molecule that's the antigen, and you chemically link it to a protein.
Why?
Because polysaccharides by themselves don't trigger a very strong, long-lasting immune response, especially in young kids. But by attaching it to a protein, you trick the immune system into treating it like a protein, which generates a much more robust T-cell memory response. The data shows it works, 90% effective, though it does need a 4-dose series.
Okay, now we need to spend some serious time on a major safety paradox in the bacterial world. Whooping cough, or pertussis, the sources have a very severe warning here.
This is a really vital public health discussion. The standard whole-cell pertussis vaccine is highly effective, no question. But it is associated with a risk of severe systemic reactions. And in rare cases, these can be fatal.
That's a terrifying risk to balance. What are the specific adverse reactions we're talking about?
They're profound. The reports include things like sustained high fever, a child becoming limp and unresponsive, what they call a hypotonic, hyporesponsive child convulsions, altered consciousness, even focal neurological signs.
Wow.
Because of this demonstrable, though rare, risk of severe neurological problems, the pertussis vaccine is explicitly contraindicated if a child has any history of convulsions or other neurological disease. Patient history is paramount here.
This just shows that constant trade-off between efficacy and safety. Let's turn to a vaccine that seems to challenge the whole classification system, BCG.
BCG, or Bacillus calmette-guerin. It's a live attenuated strain of M. tuberculosis developed way back in 1921. Its administration is really specific. An intradermal injection creates this little papule that ulcerates, scabs, and then heals over about 6 months, leaving a permanent scar.
And that scar is like a passport stamp, proof you've had it.
In many places, yes. Its main job is preventing severe childhood TB. But the sources reveal this surprising, powerful, non-specific benefit.
Wait, so it does more than just protect against TB?
It seems to. BCG has been shown to enhance immunity non-specifically. It stimulates the entire reticuloendothelial system, basically the body's general network of immune cells that cleans up invaders and debris. Gives the whole system a bit of a tune-up.
So what are the practical applications of this general boost?
Well, it's been used as an adjuvant in cancer immunotherapy, basically helping the body's own immune system fight tumor cells. And in some specific high-risk contexts, it's even been used in people with compromised immunity, like those who are HIV positive.
Yeah.
It's a fascinating case of a tool having an unexpected, broader effect.
That dual function is a genuine deep dive insight. Okay, let's tackle the complexity of viral vaccines, starting with polio, because having both a live and a killed version presents a major strategic choice.
The choice between the two polio vaccines has defined the entire global eradication effort. You have the OPV, the oral poliovirus vaccine, the Sabin one. It's live, given as 2 drops, and critically, that oral route simulates natural infection in the gut.
And why is that gut immunity so important for polio?
Because polio is spread through the fecal-oral route. By creating strong intestinal immunity, OPV doesn't just protect you from the disease, it stops the virus from replicating in your gut and spreading to others. It stops viral shedding. That's the key to herd immunity and eradication.
The other one, the IPV.
The IPV, the inactivated poliovirus vaccine, the Salk one, it's a shot of killed virus. It gives you excellent protection against paralysis, but it doesn't give you that same level of gut immunity.
Okay.
So it's used mainly for susceptibility suppression in places or for people where the very small risk from a live vaccine is just not acceptable.
Okay, next up, rabies. If there's one regimen that just screams urgency and complexity, it's the post-exposure prophylaxis for rabies.
Rabies is pretty much 100% fatal once symptoms start, so speed is everything. We use these modern, highly purified vaccines, PCV, HDCV, PVRV, but the challenge isn't just the vaccine, it's the commitment to the schedule. It's like a 3-month battle plan.
Walk us through that commitment, the WHO protocol.
It's intense. The post-exposure regimen requires 8 total injections over 90 days. Tiny little injections intradermally, right into the skin. The schedule is days 0, 3, 7, 14, 30, and 90.
8 shots over 3 months. That is a serious commitment.
It is, but it's what's necessary to build up protective immunity before that slow-moving virus can reach your brain.
And beyond the injections, the local wound treatment is just as critical, if not more so.
Absolutely mandatory. The second you're bitten, sources specify the wound must be washed for at least 10 minutes with soap and water. You have to physically remove as much virus as possible, then apply an antiseptic. And a crucial rule, no stitches for at least 2 days. You don't want to trap the virus in there.
Let's move to hepatitis B. This vaccine really highlights how far the technology has come.
The Hep B vaccine is a product of modern recombinant DNA tech. It's made in yeast cells that are engineered to produce just the surface antigen of the virus. It's incredibly safe. And because Hep B can cause chronic disease, universal immunization is recommended for all infants, and it's essential for high-risk groups.
Healthcare workers, for example.
Healthcare workers, hemophiliacs, dialysis patients.
Okay.
It's a standard 3-dose schedule. Month 0, 1, and 6.
Next, the classic combo, MMR, measles, mumps, rubella. This brings us back to that high-stakes risk assessment for certain people.
MMR is a combined, live, attenuated vaccine. It's highly effective. But the rubella component means it is absolutely contraindicated in pregnancy.
What's the specific danger there?
The live rubella virus, if it infects a fetus, can cause congenital rubella syndrome, leading to severe birth defects. And while the vaccine strain is weakened, the risk is not considered 0. So the sources are emphatic. Females must strictly avoid conception for at least 2 months after getting the vaccine. It's all about prioritizing fetal safety.
And finally, for this section, the varicella or chickenpox vaccine.
This uses the live attenuated OCUS strain, and it gives really robust protection, about 98% effective, lasting for about 10 years. It's widely recommended for kids between 1 and 12.
Okay, so we've covered the deep dive into active immunity, the long-term training. Now let's shift back to the immediate transfer, passive immunity, and the 2 main products, Antisera and immunoglobulins. And the distinction here is all about safety.
Yeah, and the distinction is based entirely on the source of the antibodies. Antisera, or ADSARs, are purified serum from animals, usually horses or rabbits, that have been immunized.
The second you say horse serum, my internal safety alarm starts ringing.
It should. Because these products contain foreign protein, your body can recognize them as non-self and have a major reaction. The risk of an immediate allergic reaction, like hives or even life-threatening anaphylaxis, is significant. The sources cite a risk of up to 1 in 1,000.
That's high.
It is. It means you have to be extremely cautious. But then, in stark contrast, you have immunoglobulins, or IGs.
The safer, more advanced alternative.
Exactly. These are human gamma globulins, separated from pooled human plasma. They're much safer because they're human-derived. They're also more effective and have a longer half-life. over 20 days for IgG, which gives you longer temporary protection.
So let's look at the standard one first. Normal human gamma globulin.
Right, NHGG. This is a concentrate from thousands of plasma donations, so it has a broad range of antibodies. It's used prophylactically to prevent things like hepatitis or measles in susceptible contacts, and it's also a key treatment for various immunodeficiency syndromes.
But when the exposure is confirmed and high risk like tetanus or rabies, you need maximum specificity. That's where the specific hyperimmune immunoglobulins come in.
Correct. These are from donors who have very high levels of antibodies to one specific threat. Take tetanus. You have the old tetanus antitoxin, ATS, from horses, versus the modern standard tetanus immunoglobulin, TIG, from humans. TIG is safer, more effective, and gives you protection for up to 4 weeks.
And this is where we get back to that idea of using active and passive defense at the same time, but with that weird logistical rule.
This is a fascinating immunological quirk. When someone comes in with a dirty wound, you give them immediate defense, the TIG, and you start their long-term training, the tetanus toxoid vaccine. But the sources mandate they must be given at a different injection site.
Why? Why not just mix them?
Well, if you injected the ready-made antibodies from TIG right next to the toxoid antigen.
The antibodies would just neutralize the vaccine on the spot.
Exactly. You'd be killing the training signal before it even gets started. So you inject them far apart, often in different limbs. That ensures the passive shield goes up immediately, while the active training signal remains strong and unimpeded.
And the same principle applies to rabies.
Absolutely. For rabies, we use anti-rabies serum from horses, or much preferably human rabies immunoglobulin, HRA. And the administration method is dictated by the virus's path. You first infiltrate it locally around the bite wounds to neutralize the virus at the entry point.
Stop it before it can travel up the nerves.
Right. Any leftover HRA is then injected into a muscle. That local saturation of the wound is arguably the most critical part of the whole protocol.
And rounding out this group, we have hepatitis B, immunoglobulin, HBI.
HBI is a human Ig solution with a super high concentration of antibody to the hep B surface antigen. Its critical use is for accidental exposure, like a needle stick injury in a hospital. And just like with tetanus, you can give HBI at the same time as the hep B vaccine to provide that immediate shield while active immunity builds.
Okay, now let's talk about the product that embodies the high-risk, high-reward calculation better than any other. Anti-snake venom serum, ASV. This takes the safety discussion to the absolute extreme.
This is a true life or death scenario where the extreme efficacy justifies the extreme risk. ASV is a polyvalent equine serum. In the context of our sources, it's derived from horses immunized against the venom of 4 common Indian snakes: cobra, Russell's viper, saw-scaled viper, and krait.
So you are injecting massive doses of foreign protein derived from 4 different immunization processes into a critically ill person.
Precisely. And the administration is rapid and intense. It's given intravenously, diluted in saline. Dosing depends on how bad the bite is. It starts with 1 or 2 vials, but could require a staggering up to 30 vials in severe cases.
30 vials of horse serum. The risk of a severe allergic reaction must be through the roof.
It's constant and extremely high, which means the clinician is treating 2 things at once.
Yeah.
The snake bite and the potential for anaphylaxis from the cure.
So you have to have the emergency meds ready to go.
It's mandatory. The sources are unequivocal. Because of the high risk, adrenaline, antihistamines, and corticosteroids must be immediately on hand for the entire infusion process. The cure, in this case, carries its own profound risk.
We've examined the mechanisms and the specific tools. Now we need to consolidate the practical realities of safety, logistics, and scheduling. Because how you administer these products is just as important as what's in them.
Let's start with the baseline precautions. The sources are clear. You should avoid or at least put off vaccination if someone has an acute infection, especially a respiratory one. You want the body at its best to mount a good response.
We've talked about the dangers of animal proteins, but even the vaccines themselves can carry trace components that cause allergic reactions.
Yes, vaccines are complex biological formulas. They can have trace amounts of other materials from the manufacturing process. Things like residual antibiotics or egg proteins if the vaccine was grown in eggs, which was common for older viral vaccines.
And since a severe allergic reaction, anaphylaxis, is a real, if rare, possibility with any injection, what's the mandatory emergency protocol?
The protocol is firm. An adrenaline injection, specifically at a 1 in 1,000 dilution, must be available and ready to go the instant any allergic reaction is seen. It underscores how seriously these products have to be handled.
Let's go back to the risks with animal-derived products, the Antisera and talk about the delayed threat of serum sickness.
Right, so immediate anaphylaxis is the most dramatic risk, but this delayed reaction is far more common. When you introduce foreign proteins like Hort serum, your body eventually recognizes them and mounts this slow, complex immune response against them.
What does that look like and when does it happen?
It's a delayed hypersensitivity reaction, and it typically shows up 7 to 12 days later. The symptoms are systemic and miserable: fever, a generalized rash, severe joint pain, swollen lymph nodes. Our sources say this happens in a significant 5 to 10% of cases.
5 to 10%. That's a huge driver to develop human-derived products.
It's the core public health driver for that technological shift, yes.
Okay, we have to now consolidate all this into its practical roadmap. The National Immunization Schedule, the NIS. The schedule dictates exactly when and which combination of vaccines a person gets across their life.
The NIS is a masterpiece of logistical planning. It's designed to get that immune training started at the earliest safe moment for the most vulnerable people, infants and pregnant women. It's the accumulated wisdom of all the data we've just been talking about.
So let's detail the critical milestones for infants and kids, starting right at birth.
The foundation is laid at birth, or within 15 days, with 3 key shots: BCG for TB, OPV0 to prime the gut against polio, and Hep B0, the first dose for hepatitis B.
Then the schedule gets really intense in the first few months with the combined products.
Yes, at 6, 10, and 14 weeks, the child gets the pentavalent vaccine in 20 successive doses. That single shot covers DPT, Hep B, and Hib. They also get more OPV and the rotavirus vaccine. And at 14 weeks, a fractional dose of the IPV, the injected polio vaccine, is added to boost systemic immunity. That pentavalent stack is doing incredible work.
But that brings us back to that policy debate. While it's efficient, are there consequences to stacking so many antigens together?
The sources raise a valid point. Combining vaccines is great for adherence and logistics, but some experts have raised concerns about whether the immune response to one antigen might be slightly weaker because of the other 4, or if the side effects from the pertussis component get worse when combined. It's a debate about balancing efficiency and absolute immunological efficacy.
And then we move into the toddler and preschool years, the booster phase.
Between 9 and 12 months, the child gets their first measles rubella dose. Then at 16 to 24 months, it's the first DPT booster, the second measles rubella, and another OPV booster. You're solidifying that long-term memory. And finally, between 5 and 6 years, it's the second DPT booster and a tetanus toxoid dose.
And finally, what about pregnant women? There's a specific regimen for tetanus.
This is crucial for preventing neonatal tetanus, which is devastating. Pregnant women need 2 doses of tetanus toxoid, about 4 weeks apart. This protects both the mother and the newborn. It's a simple but incredibly life-saving intervention.
So if we connect all these threads, the whole immunological arsenal is this incredibly sophisticated system of checks and balances.
It really is. And the key knowledge we synthesized today all revolves around that one distinction: active, long-term training from vaccines and toxoids versus passive, immediate reinforcement from Antisera and immunoglobulins. That choice dictates everything.
We've seen the sheer logistical commitment, from that 3-month battle plan for rabies PP to the permanent scar from the BCG vaccine, which also gives that surprising non-specific immune boost. And of course, the dramatic danger of equine anti-snake venom, where the life-saving action is inseparable from the high risk.
Right, and the sources give us a clear spectrum of the challenges, from optimizing a combined product like the pentavalent vaccine to balancing the profound safety risks of the pertussis component against the severity of the disease itself.
So what does this all mean for you? Our final provocative thought for the learner is this. We get the mechanical difference between active training and passive protection now. But when you look at high-stakes policies like the National Immunization Schedule, the efficacy of these products varies wildly, from 72% for 3 years with a typhoid vaccine to near total protection with MMR. So how should public health strategies ethically weigh the pursuit of perfect long-term immunity against the immediate high-risk demands of a crisis? And how do those constraints ultimately drive innovation towards safer yet equally powerful new combinations?